So the concept of EVLP, or even ex vivo organ perfusion in general, dates back as far as 1935, but it wasn't until 2009 that the first clinical case was completed. So Stig Steen and colleagues based in Sweden got marginal lungs that had been rejected for transplant. They ran them on an EVLP circuit, they reconditioned the lungs, and the lungs were ultimately able to be transplanted into a recipient. So the technique was originally developed for the transplant world, but around the same time, so in 2009, Michael Mathey, who is a leading ARDS expert, realised that the technique could also be used to model acute respiratory distress syndrome. So for those of you that might not be familiar with ARDS, it is a debilitating syndrome characterised by an acute hypoxia, an inflammatory edema, general dysregulated inflammation, and large-scale infiltration of inflammatory cells such as neutrophils. The mortality for ARDS remains stubbornly high at approximately 40%, and that's despite many decades of research. And ARDS became particularly topical in the last few years as the most severe COVID infections were giving rise to ARDS. So the Berlin definition is how ARDS is currently diagnosed, and there are four main criterion. The first is timing, so the patient must present within 1 week of a known clinical insult or new or worsening respiratory symptoms. The second is chest imaging, so if you were to do a chest x-ray or a CT scan, you should see bilateral opacities. The origin of edema is the third criterion, and this is described as respiratory failure not fully explained by cardiac failure or fluid overload. And then the fourth is oxygenation, so patients are dichotomized into 3 different categories, namely mild, moderate, or severe, based on the severity of their oxygen deficit. So in Beaumont, we use the LS1 machine. So this was produced by Ex Vivo, and it's one of the first machines that was made for the purpose of EVLP. To date, models of ARDS using EVLP have been limited to live bacteria or LPS models, so lipid polysaccharide, which is an endotoxin found on the outside of gram-negative bacteria. But we wanted to develop an additional model, so our model is ventilator-induced lung injury combined with LPS, which is a common 2-hit model of acute respiratory distress syndrome. As well as this, both human and porcine lungs have been used in EVLP research. We're currently limited to porcine lungs, but pigs have the most similar anatomy and physiology to humans, so it's not necessarily a limitation as such. So if we look a little bit closer at the layout of the circuit, you can see that there's a white reservoir, so the lungs sit into this basin, and then the fluid that's in the lungs drains out into the reservoir just at the bottom of the basin. There are pressure transducers which measure the pressure in both the lung itself and in the circuit. We have a vent attachment, so these lungs are ventilated. They have an endotracheal tube, and then this is how they connect to the vent. There's a membrane gas exchanger, so this either supplies or withdraws oxygen and or mixed venous gas depending on the phase that you're in the machine. There's temperature probes which measure the temperature both in the lung and in the perfusate. There is a water inlet which provides the heat to the gas exchanger. The gas inlet which provides the gas. The perfusate is pumped around the LS1 using a roller pump, and then there's a waste outlet, so we can drain all of the fluid out of the machine at the end, and we can also clean it. So there are a number of different protocols in circulation. There are 3 main ones. These are called the Toronto, the Lund, and the OCS, and they're based on perfusion and ventilation parameters. So for perfusion and target flow, this ranges from 40 to 100% of cardiac output, and we typically use 40%. Pulmonary artery pressure can be either flow dictated or set to less than or equal to 20 millimeters of mercury. We generally use the target of less than 20 millimeters of mercury. The left atrium can be closed or open, and we keep ours open. The perfusate can be Steen solution, or it could be supplemented with red blood cells. We make our own Steen solution, so it's a balanced solution containing electrolytes and albumin, and we also supplement with 10% whole blood. In terms of ventilation, your start temperature can range from 32 to 34 degrees Celsius. We use 32 with a target of 37. Tidal volume ranges from 5 to 7 mils per kilo of body weight, and we use 7. The respiratory rate in the protocols range from 7 to 20, but we actually use 5. So this is the rate that we need to maintain a physiological PaCO2 in the circuit. PEEP, which is positive end expiratory pressure. This is the pressure that keeps alveoli open at the end of expiration, and it has a protective effect. People generally use between 5 and 7 centimeters of water pressure. We use 5, and then the fraction of inspired oxygen can range from 12 to 50, and we use 50. So as I mentioned, Evlp is compatible with human and large animal lungs. We're currently using pigs. We use all female pigs. They're approximately 20 kilos in weight, and the strain is the white landrace. So I'm just going to take you through the methodology for the model. So the animals are anesthetized and euthanized, and then we have a period of 10 minutes of no touch. So this is to ensure cessation of heartbeat. Then the animal is intubated, they're ventilated using protective volume control and ventilation. For us, this looks like a respiratory rate of 12, a tidal volume of 7 mils per kilo, a PEEP of 5, and a fraction of inspired oxygen of 0.3. Then they receive a recruitment maneuver, so this is just the delivery of high pressure for a short period of time, and it helps to open any alveoli that may have collapsed during the initial procedure. And then we surgically explant the lungs. Once the lungs have been explanted, they're flushed to ensure that there's no remaining blood clots in the lung. The lung wet rate is recorded, and they go on ice for 2 hours, which is called static cold preservation. Then we set up the machine, and the lungs undergo a period of rewarming, which typically takes an hour. During this, we're trying to maintain target flows, pressures, and temperatures. And at the end, at full flow, full ventilation, full temperature, the machine is switched to evaluation phase. So if during this phase the supplemental oxygen from the machine is taken away, but the vent oxygen is increased to 100%, and we do an arterial blood gas by sampling from the pulmonary veins, and this gives us an indication of the gas exchange capacity of the lung. We also take perfusate samples, which we store for future analysis on things like pro-inflammatory cytokines, and this is repeated every 60 minutes. And that starts our 6-hour timing. So there's a recruitment and recording of variables also every 30 minutes. And at the very start, once we've established that the lungs are healthy, we initiate our ventilator-induced lung injury protocol. So this is injurious pressure controlled ventilation. There's a respiratory rate of 5, a peak inspiratory pressure of 25 centimeters of water pressure, and a PEEP of 0. We also add 20 mg per kg of LPS into the perfusate.